Okay, I'm going to start. I'm sure more people will trickle in. Um, so good morning and welcome, and thank you for coming to listen to my talk. And the topic of today's is this working? Yes. So the topic of today's rounds is anaphylaxis investigation. I did this talk 2 years ago, and Dr. Jelka Lujic, the anesthetic anaphylaxis guru, one of them in Canada, helped me with it. She was a member of the anesthesia department at the University of Alberta Hospital, where I was doing my residency at the time. And she's now in Ottawa and continues her work in anaphylaxis in anesthesia. And I wanted to share this information with you and then look at ways we can improve our follow-up to anaphylaxis here at our site. Different studies and articles, as well as discussions with some of our department members and anesthetists with a special interest in anaphylaxis here in BC, suggests that follow-up after anesthetic anaphylaxis is not always optimal, and we will be looking at options to improve the flow of patient anesthetic allergy information, an aspect that has potential medico-legal consequences. So my objectives today are to emphasize the importance of not missing the diagnosis and not underreporting the events. Secondly, to inform you guys about the available investigations and follow-up for perioperative anaphylaxis. And thirdly, to step back and discuss options for our department to streamline the process of reporting, investigating, referral, and follow-up after an allergic event in the operating room. So the structure will be, we'll start with 2 clinical cases to demonstrate some points of discussion. Then we'll quickly look at the considerations in anesthesia and go through the definition, clinical presentation, epidemiology, and common causative agents. I will explain the diagnostic tests to you, and I'm hoping to entertain you with some new information on specific anesthetic drugs. And then the most important part will be about anaphylaxis investigation, how it was done in Edmonton, where I did my residency, and new developments here in Vancouver, how other countries like France are doing it, and how we can improve it. So the first case was reported to me in response to the email I sent out last week. So a healthy 30-something-year-old female came for an elective surgery at Eagle Ridge last year. The procedure is forgotten, but it was planned to be done under GA, and the patient was from France, had no history of drug allergies, and no history of previous anesthetics. On induction, she received fentanyl, propofol, lidocaine, and rocuronium. And around the induction period, she had a prophylactic antibiotic, Ancef. And about 5 minutes after induction, the patient became hypotensive. This was corrected with fluid and vasopressors. And in search for a cause, it was seen that the patient had hives and also mild increased airway pressures. The patient was stable after the initial fluid bolus and vasopressors. I don't believe epinephrine was given due to the sustained good response to the initial treatment. So it was decided to complete the surgery. The surgeon was asked to switch out his latex gloves to non-latex. Ranitidine, hydrocortisone, and diphenhydramine was given. Surgery was completed, and the patient was observed for an extended period in the PICU. She remained stable throughout and was sent home later that day with her sister, who is a nurse. She was given a referral letter to an allergist listing all drugs used and a description of the event. And there are a few learning points from this case. Firstly, this patient is from France, and later on we will be looking at the increased incidence of rocuronium allergy in certain countries. But more importantly, we have no idea whether this patient eventually saw an allergist or whether they had the correct allergy testing done. And this patient is at risk of having an anaphylactic reaction under anesthesia in the future. So the question is, did we do enough to ensure good follow-up, or are we obligated to do more? So I was directly involved in the second clinical case while I was on my regional rotation at the University Hospital in Alberta in 2011. The patient was a 25-year-old male for pinning of a fractured metacarpal. He was healthy with no known allergies. And having gained informed consent for a supraclavicular block, I took the patient over to the designated block area that was adjacent to the PICU. I started an IV and attended him and attached him to the necessary monitors in preparation to perform regional anesthesia. And one of the many anesthesia assists that we have there that actually crowd around the central core, and then they're at hand whenever you need them. It's really like that. Their central core is just next to a row of 8 C-arms waiting to be used as well. So one of them was with me. So I scanned the patient and for the necessary anatomy, and then waited for the attending staff and anesthetist to come before starting the block. So I was standing next to the patient when I heard a sudden significant increase in the heart rate on the monitor. I immediately looked down at him, asking if he was okay. I noticed a profound change in his level of consciousness, as he could hardly verbalize that he was feeling severely itchy. My first thought was that we had not even given him any drugs yet. So that prompted me to look up at the IV bag, and then I saw the empty cefazolin little bag hanging there, which the AA had attached and given to the patient, seeing that he had no allergies. And then the diagnosis was confirmed by the presence of an angry rash when I pulled the gown away over his chest. So we immediately called for help. The crash cart came. His systolic blood pressure went as low as 38, but he had no upper or lower airway symptoms. So just the rash and the hypotension. And he responded very well to 250 micrograms doses of epinephrine and IV fluids. He didn't require intubation. And surgery was deferred, and he was observed in hospital for more than 24 hours, and blood work was done using the protocol stickers and anaphylaxis kit they have in Edmonton, which I will tell you about later. Referral forms for allergy testing were completed and faxed to a designated allergist, and the tryptase levels at 30 minutes after start of allergic reaction was significantly elevated at 46 microgram per liter. A year after the incident, I did an electronic search for his consult. It is a provincial system in Alberta, which makes it easier to find information. It's called Netcare. No consult or allergy test results were found. So even with a formalized protocol, the follow-up was not sufficient. Although the patient was told that he had a severe allergic reaction to penicillin-like antibiotic before he left the hospital, there is no proof on paper that he is aware of this potential life-threatening condition. So in the second clinical case, the diagnosis was easy to make, and it was quite obvious that the cefazolin was the most likely culprit. But usually the greatest obstacle to effective treatment of anaphylaxis is recognition of the reaction in the first place, because many factors confound the correct diagnosis. Anaphylaxis is most commonly seen near the beginning of an anesthetic, when changes in cardiovascular status can be attributed to other more common causes, such as hypotension from induction agents, as well as effects of patient positioning or peritoneal gas insufflation. By the time that the diagnosis is made, a patient has most likely been exposed to multiple drugs, blood products, and other foreign substances, making it hard to know what the cause is. Furthermore, a significant amount of surgical patients have underlying systemic disease, and exhibit some of the same cardiovascular and respiratory changes under the stress of surgery, as is seen in anaphylaxis. And some patients do not develop a rash, which makes it more difficult to diagnose, and patients are often covered by surgical drapes. Now, more than 90% of allergic reactions evoked by intravenous drugs occur within 5 minutes of administration. But delayed reactions can occur, such as in the case with allergy to latex and chlorhexidine. A further pitfall in the recognition, because you may not have given anything for the past hour and suddenly the patient develops hypotension and a rash or whatever. So the point here is a high index of suspicion is necessary. So our patients are exposed to a multitude of foreign substances when they come to the operating room. The ones we tend to forget about are the antiseptics and the volume expanders. So just keep that in mind. Now, we all know that the classic pathophysiological definition of anaphylaxis is a type 1 IgE-mediated reaction. In the past, the term anaphylactoid was used for severe non-IgE-mediated allergic reactions. Anaphylaxis is now more commonly defined clinically as any severe systemic hypersensitivity reaction of rapid onset, which may cause death or other adverse outcomes. So the term anaphylactoid should no longer be used, and these definitions are of marginal utility anyway when you're standing there as a physician busy treating the patient. So this is the Ring and Mesmer Clinical Severity Scale, which was adapted to describe perioperative immediate reactions. Sorry, I'm just losing my mic here. Sorry. So one key issue of anaphylaxis is that a very small amount of allergen is sufficient to cause quite a severe reaction. The involved target organs commonly include the skin, mucous membranes, cardiovascular and respiratory system, and sometimes the gastrointestinal tract. And the corresponding clinical signs are erythema, edema, pruritus, arterial hypertension, tachycardia, and bronchial and gastrointestinal smooth muscle constriction. Epidemiology. So the overall incidence of perioperative anaphylaxis is estimated as 1 in 10,000 to 1 in 20,000 anesthetic procedures. In France, the incidence is estimated at 1 in 13,000, but then that goes to 1 in 6,500 where a neuromuscular blocking agent is given. Its exact incidence remains underestimated as reactions are underreported. Even in a country like France, where a national reporting system is in place, it has been estimated that underreporting is as high as 30%. With regards to morbidity and mortality, morbidity remains unknown, and mortality is estimated at 3.4% of anaphylactic reactions. In France, 3% of deaths that are partially or totally anesthesia-related involve anaphylaxis. And 10% of perioperative immediate hypersensitivity reactions reported to the United Kingdom Medicine Control Agency are fatal, but that's maybe a bit high because it is thought that less severe reactions are underreported. At the University Hospital in Edmonton, Dr. Lujic implemented the anaphylaxis protocol that they have there at the end of 2004. So this included a poster with a protocol for management, blood sampling, and referral of patients with possible allergic reactions. She also had a reporting system and was keeping track of all the cases over this citywide. 31 cases of anaphylaxis were reported to her over a 7-year period from the 4 hospitals. And these included adults and children, so the Stollery Children's Hospital as well. On average, they do... Oh, sorry, this was just at the University Hospital, not citywide, actually. So it's the big University Hospital and the Children's Hospital. So on average, they do 10,000 anesthetics in pediatrics and 10,000 per year in adults. So that adds up to 20,000 anesthetics. And over 7 years, the incidence of anesthesia-related anaphylactic reactions at the University Hospital there was roughly calculated as 1 in 5,000 anesthetic procedures. So it is agreed that antibiotics, neuromuscular blocking agents, and latex are the 3 most common causative agents in anesthesia. In France, neuromuscular blocking agents were shown to be the most common agents involved, followed by latex and antibiotics. In a Norwegian single-center study, neuromuscular blocking agents were most commonly involved, with latex implicated in very few cases, with no agents identified in 1/3 of cases. Conversely, in 2 Spanish centers, antibiotics, followed by neuromuscular blocking agents, were the main agents involved. And then a retrospective study published in Anesthesia Analgesia 2011 reviewed the records of all patients who were tested for perioperative and anesthetic allergic reactions at the Mayo Clinic Division of Allergic Diseases and Skin Testing from 1992 to 2010. And they included that antibiotics were the most common likely causative agent associated with IgE-mediated allergic reactions. However, in 52% of reactions, they could not find any causative agent. So anaphylaxis to, just a little bit more about the neuromuscular blocking agents, is not uncommon in patients with, allergic reactions to a first dose of a neuromuscular blocker is not uncommon. And when this happens, it is, you have to wonder what the source and nature of the sensitizing agent is. So the quaternary ammonium ions, that's part of all the neuromuscular blocking agents, are thought to be the epitope part that makes people react allergically to them. And commonly used chemicals such as toothpastes, detergents, shampoos, and cough medicines share these determinants with the neuromuscular blocking agents. So in a predisposed individual, these common chemicals might be one of the contributing factors promoting sensitization to quaternary ammonium ions, and then creating the risk of developing anaphylaxis to our neuromuscular blocking agents. It has been suggested that the sensitization to quaternary ammonium ions seems to be related to exposure to Falkadine, which is a cough-relieving medicine. It is available over the counter in Norway and France, but not in North America, not in any of the other Scandinavian countries or European countries. So France and Norway are reporting a much higher incidence of anaphylaxis with rocuronium, which at some point led to the Norwegian Medicine Agency to publish an alert to reserve rocuronium only for emergency inductions where you cannot use succinylcholine. But then after that, I'm not sure if that still exists, but after that, Falkadine was withdrawn from the market, and within 3 years of that, the number of allergic reactions to neuromuscular blocking agents was significantly reduced. So this supports the hypothesis because the number of antibodies to Falkadine rapidly decline after 2 years of non-exposure. And also in Australia, it has been suspected that many over-the-counter cough medicines containing Falkadine may very well be related to sensitizations of patients. And even though it has not been fully proven, some suggest that it should be withdrawn from over-the-counter type cough medicines. So, and then also cross-reactivity between muscle relaxants is estimated to be about 60 to 70%, but one patient is not usually allergic to all muscle relaxants. Some advise that if a patient is proven to have an allergy to one, they should be tested for the others. This would give valuable information for future safe anesthetics. So the etiologic diagnosis of immediate reaction occurring during anesthesia relies on a triad, including clinical and then biological and allergologic evidence. So first evidence is the clinical history, which is crucial. The initial diagnosis of anaphylaxis is presumptive, although essential. And the first line of evidence for the diagnosis includes the features and severity of clinical signs and the timing between the introduction of the suspected allergen and the onset of symptoms, whereas the required dosage for resuscitative medicines gives insight into the severity of the reaction. And then second evidence refers to biological assessments that can contribute to diagnosis. Primary biological tests are histamine and tryptase levels. Histamine is performed and contained in preformed and contained in granules of mast cells and basophils. An early increase in plasma histamine concentration indicates activation of mast cells and or basophils and is observed during allergic and non-allergic mechanisms. And conversely, the absence of histamine increase does not preclude an immunologic or non-immunologic mechanism. The plasma half-life of histamine is thought to be really short, 15 to 20 minutes. Blood samples for histamine measurements should therefore be drawn within 30 minutes after onset of reaction, and it should be kept on ice. I'll tell you more about that in a minute. Tryptase is a mast cell neutral serine protease and a preformed enzyme. So serum tryptase concentrations reach a peak between 15 minutes and 1 hour and decline under first-order kinetics with a half-life of approximately 2 hours. Therefore, blood samples may be drawn within 15 to 60 minutes of grade 1 and 2 reactions, that ring of Mesmer reaction grading, and within 30 minutes and 2 hours in more severe grade 3 and grade 4 reactions. An increase of tryptase concentrations is highly suggestive of mast cell activation as seen in anaphylaxis, but absence does not preclude the diagnosis. To compare the concentrations with baseline levels, a new sample of tryptase can be taken either at least 24 hours or after the initial reactions or at the time of investigation. Baseline levels vary between patients, so that's why that needs to be done. So then second investigation refers to IgE assays. It's not very sensitive or practical, but I'll just quickly run you through what that means. So in vitro specific IgE assays are available for only certain drugs, and those are succinylcholine, thiopental, propofol, and the following antibiotics, amoxicillin, cefaclor, GV, and also for latex. So no neuromuscular blocking agent specific IgE assay is currently available except for succinylcholine, and its sensitivity remains low, 30 to 60%. As mentioned, it's the quaternary ammonium ion are considered to be the major allergenic epitope in IgE-mediated anaphylaxis to the neuromuscular blockers. So morphine, succinylcholine, and acetylcholine also have quaternary ammonium ions and have been used to as markers to look for the presence of IgE antibodies to neuromuscular blocking agents. And then in France, they also use Valcadine because it also has that to look for antibodies. And in Edmonton, the blood for neuromuscular blocking agent IgE assays were sent to France. Once again, a sign of the the excess that exists, I guess. But anyway, so Dr. Lujic spoke to the Dr. Saint-Laudy. He's the anesthesia anaphylaxis guru in Paris, and they were talking about which allergen to use to test. And she was asking, should we use the Valcadine one? But they agreed that that might cause an increased degree of false negatives just because Canadians are not exposed to Valcadine. And so you might miss diagnosis. But nevertheless, indirect or specific IgE assays seem to be less sensitive than skin tests. And not to mention sending blood to France is an expensive and labor intensive. So third evidence is skin tests and remain the gold standard for the detection of IgE-mediated reactions by exposing the mast cells of the skin to the suspected allergen in patients who have experienced anaphylaxis. We know that pre-medication with H1 and or H2 receptor antagonists and corticosteroids does not prevent anaphylaxis in susceptible patients. Therefore, skin tests are a tool to identify and avoid the culprit agents in the future. A 6-week delay after the reaction is required to avoid false negative test results because of mast cell depletion of histamine and tryptase. And all drugs injected just before reaction, as well as latex, must be skin tested. And skin tests must be read after 15 to 20 minutes. And before test agents, the cutaneous reactivity should be assessed with a negative, saline, and a positive, and for that they use codeine and or histamine. So freshly prepared commercial solutions, diluted or undiluted, are used to perform a skin prick test first, and if negative, an intradermal test. Intradermal tests are more sensitive, but less specific than skin prick tests. Intradermal tests are more likely to cause a systemic reaction and should only be performed after a negative skin prick test. And for each solution, there is a maximum concentration which should not be exceeded, as this could lead to irritation and false positive results. Intradermal testing is done starting at a low concentration, and if negative, the concentration is increased by 10-fold every 15 to 20 minutes until positive or the highest non-irritant concentration is achieved. And the criteria for prick test and intradermal test positivity and the different concentrations of anesthetic drugs that are normally non-reactive have been strictly defined in France, as seen in this table, and these rules have been adapted by others as well. So now we'll talk about specific drugs. So what does Humpty Dumpty and Michael Jackson have in common? The debate about egg allergy and the safety of propofol administration in such patients is ongoing. So egg allergy is a common food allergy reported to us. And on the other hand, propofol hypersensitivity reactions are uncommon. Propofol preparations are lipid suspensions that contain egg lecithin or phosphatide from egg yolk. Most people are allergic to egg white proteins. There is still no agreement among physicians regarding propofol in patients with egg allergy, with some suggesting that egg allergic patients are not more likely to develop anaphylaxis when exposed to propofol. The 2009 guidelines on anaphylactic reactions associated with anesthesia, published by the Association of Anaesthetists of Great Britain and Ireland, claim there is no evidence that propofol should be avoided in egg allergic patients, but suggest a cautious approach is required in such patients. So there have been 5 published cases of suspected allergic reactions to propofol in egg allergic patients. But in 2 of these, allergy to egg seemed speculative. In 4 of these cases, other medications were given concurrently, and none of these patients were follow-up or had a reported skin prick test or intradermal testing to propofol after the events. So, published in Anesthesia and Analgesia 2011, a retrospective chart review of propofol administration to egg-allergic pediatric patients at the Children's Hospital in Westmead, Sydney, Australia, for 1999 to 2010 was performed. A total of 1,162 egg-allergic patients were identified by the search. Of these, 230 had undergone a procedure under anesthesia, with only 42 patients having propofol administered. Only 2 patients had a history of egg anaphylaxis. There was only 1 allergic reaction after propofol administration. This was in a 7-year-old boy with a history of multiple IgE-mediated food allergies to egg, cow's milk, nuts, and sesame, who had never had a general anesthetic, propofol, or intralipid. This patient had a history of anaphylactic reaction to egg, which was confirmed by skin prick test. 15 minutes after his last dose of propofol, while in the recovery room, he developed generalized erythema and urticaria treated with epinephrine. 3 months later, a skin prick test to propofol was positive. So the conclusion of the study was that propofol is likely to be safe in most egg allergic patients. However, there were only 2 patients with history of egg anaphylaxis in this study. So therefore, until further evidence from prospective study is available, they suggest that propofol should not be administered to any child with a history of full-blown egg anaphylaxis. The antibiotics, so a history of penicillin allergy is very common in our patient population. One issue is how to manage the patient with a history of penicillin allergy when the surgeon requests cephalosporin administration. Some consider that cross-reactivity to cephalosporins among penicillin allergic patients is high and suggest choosing a different drug. This clinical practice most likely evolved from case reports from 40 years ago of anaphylaxis with first-generation cephalosporins, together with in vitro testing which showed extensive cross-reactivity between penicillin and first-generation antibiotics, cephalosporins. However, the clinical relevance of the in vitro cross-reactivity was never demonstrated, and more recent publications document the risk of acute cephalosporin reactions amongst patients with a positive penicillin skin test at about 4.4%, compared with 0.6% amongst patients with negative penicillin skin tests. So that's not very much higher than the normal. One authority has concluded that most patients who have a history of penicillin allergy will tolerate cephalosporins, but that indiscriminate administration cannot be recommended, especially for patients who have had serious acute reactions to beta-lactam antibiotics. So we are sometimes faced with the clinical situation where a patient with history of penicillin allergy has a positive culture for microorganism that is only sensitive to one type of antibiotic. This is where it becomes difficult to avoid beta-lactam antibiotics. A good example is in the ICU setting, where I believe the favorite drug still is Piptazo for ventilator-associated pneumonia, and that's when you run into difficulty with patients with penicillin allergies. So penicillin skin testing, when available, can be useful in identifying the 85% of patients with histories of penicillin allergy who are actually not allergic to penicillin, and would then have negligible risk of beta-lactam antibiotic reactions. If a patient's penicillin allergy history is consistent with anaphylaxis and skin testing is unavailable, then beta-lactam antibiotics should be used with caution, or avoided, or with graded dose escalation after first dose. With regards to the opioids, it's a common complaint once again from our patients, but true allergy is exceptionally rare. On questioning, most allergies to opiates are side effects, as you know, stomach upset, pruritus, nausea, hallucinations. Most allergic type reactions to opiates involve codeine, morphine, and meperidine. And a common reaction to these opioids is what they call a pseudoallergy, and is caused by histamine release from cutaneous mast cells, a non-immunologic effect. It can look like a true allergy with pruritus, flushing, sweating, hives, tachycardia, and hypotension. True allergy to opioids seem to be IgE mediated or T-cell mediated. Allergic skin reactions in opiates include hives, maculopapular rash, erythema multiforme, or pustular rash, and reports suggest that angioedema is usually a manifestation of a true allergy. Severe cardiovascular symptoms or bronchospasm should be taken as a true allergy. When a patient has a true allergy to one opioid, they are thought to be less likely to react to an opioid of a different structural class. But because true allergy is rare, there's not enough information to assess the chance of cross-reactivity. It is important to note that there is evidence that there are patients that are allergic to more than one narcotic class. When choosing an analgesic for a patient with a history of true allergy to opiates, the benefit of an opiate must obviously be weighed against the risk of serious reaction, and there are other options of, and the following should be seen. So if the patient only has some itching and hives and mild hypotension, usually you can go for still give the opiate and give antihistamine, or you can switch to a lower dose of a more potent opiate. And then also consider, obviously, adjuncts like regional. And if an opiate is necessary, choose one of the different structural class and monitor the patient closely. And just a reminder of the different structural classes of the opiates there. Then with regards to latex and food allergies, patients who have experienced clinical manifestations of allergy to avocado, kiwi, banana, chestnut, and buckwheat are considered at increased risk of reaction to latex because of the high rate of cross-reactivity with latex. This is like Class D recommendation from a non-randomized prospective study, so it's wishy-washy at best. But what we do know is also a reminder, and everybody knows this about kids with spina bifida, and then we do know that healthcare workers and people who work in the rubber industry are more likely to have latex sensitivity. Okay, so now we get to the most important part. Australia and France and the United Kingdom have countrywide guidelines for the management and investigation of anesthesia anaphylaxis. Canada and the US have no formal reporting system of guidelines. The University Hospital of Alberta is one of only 2 centers in the country with a formal protocol. Ottawa is the other center. The rest of this presentation will be about how we can set up a simple system to improve follow-up here at our facility and options for future reporting systems here in Canada. Seeing that other countries already have guidelines, it will not be reinventing the wheel. It will simply be to find a way of implementing national guidelines and a central reporting system that is practical. We were speculating, Dr. Lujic was when we were talking about it, whether involvement of the Canadian Anesthesia Society would be indicated in trying to figure out a guidelines or a central reporting system. So this is just to show you the anaphylaxis poster on the wall in each OR at the University Hospital in Edmonton. It gives instructions on collecting blood for allergy testing. It gives the most pertinent of these being histamine and tryptase levels within 15 to 60 minutes after onset of the event. And secondly, it gives information on the referral for allergology consult. Allergology fax numbers were on there, and there were pre-typed referral forms available for completion. So this is the list of the contents of the anaphylaxis investigation kits that we had in each operating room at the University Hospital. Each kit contained tubes, stickers, lab request forms, and requests for allergology consult, and an anaphylaxis protocol information sheet. It did not contain any drugs for the management. Ottawa has the whole this, plus they have some drugs in their kit: epinephrine, hydrocortisone, methylprednisolone, diphenhydramine, ranitidine, salbutamol, an aero chamber, and a nebulizer mask with tubing. That's what they have in their kit. And they don't have a kit in every operating room. They have a central kit, kind of like the MH cart. So, and that way it's easy to keep the drugs updated in the kit. This is what we have currently at RCH in every operating room in our little crisis booklet. Anaphylaxis is rare, but it will bite you in the bum. I'm quoting one of you guys. So if you don't recognize and treat appropriately in a timely fashion, it can have severe, obviously, adverse outcomes. So this concise summary is very good during the initial management and a good reminder for the treatment of something that you will only see once or twice in your career, probably. Having this in every operating room is brilliant, but what I would like to add is one central type of anaphylaxis kit, like in Ottawa, kind of like the MH card, but probably much smaller. I've spoken to Jackie about it, with the drugs that Ottawa has, and then a protocol for blood work and follow-up. I think it would simplify things in the moment, and even more importantly, I would like to streamline the referral and follow-up process. So the French guidelines in 2005, guidelines were published for reducing the risk of anaphylaxis during anesthesia. They were implemented under the auspices of the French Society of Anesthesia and Intensive Care, and represent a consensus of international experts in the field. Of interest in these guidelines are the listed responsibilities of the primary anesthetist. Firstly, of initiating the investigation in collaboration with a consulting allergist. Secondly, you're obligated to inform the patient about the nature of the reaction and make recommendations for subsequent anesthetics. And thirdly, of reporting the event if a drug or latex is suspected to be the causative agent. So with regards to follow-up on results, the guidelines state that close collaboration between the allergist and the anesthetist is essential within the frame of an allergy consult. A full report of the results written by the allergist is to be addressed to the anesthetist. The report must be included in the patient's medical records, and copies must be sent to the regional pharmacovigilance center that they have there. The conclusion must be transmitted to the patient by the anesthetist, giving the patient a written copy of the document. And the patient should be encouraged to carry this written document with his identity papers and to wear a bracelet or have a tattoo or some form of signaling the allergy. And finally, the advice concerning matters of anesthetic technique and indications can only come from an anesthetist, obviously. In Canada, we have no such guidelines, and despite the fact that Edmonton is one of the only big centers in the country with a protocol, they are obviously lagging far behind to what the French guidelines recommend. And Canada Health has a site called Adverse Drug Reaction Website, and Dr. Lujic was thinking of making it mandatory to report to such a website so that patient allergy records are easily available. So the levels of follow-up is firstly anesthesia. So the anesthetist who was involved refers to an allergologist for a consult. The consult should contain a detailed history of the event and clearly state all the drugs and substances involved. So a little story: in Edmonton in 2006, there was a patient who came for a Whipple's procedure. She had a history of latex sensitivity scribbled somewhere on her chart. And then one of the nurses decided that it was not significant or didn't read it, but apparently just decided it was not significant and used latex gloves. The patient proceeded to develop severe hypotension and tachycardia, which responded well to epinephrine, and then was referred to the designated allergologist in the city. He got the referral, and he decided that it didn't sound like a latex allergy, so he didn't test for it. And then in trying to see why that is, the original referral was examined, and it turns out that the history of what transpired with the latex gloves in the operating room was scribbled in a corner on a fax consult, and the allergologist didn't see it, or it was not, he couldn't read it. So this just demonstrates the importance of a clear, complete history, and which should include all drugs administered and mention of previous allergies and sensitivities. It should not be forgotten to mention any antiseptic preparations used prior to the allergic reaction. Chlorhexidine is now known to be more allergenic than iodine and should be listed if used. It is prudent for the primary anesthetist to inform the patient of his allergy. And a study in Fisher et al. In New South Wales, Australia, to investigate the efficiency of follow-up after anesthetic anaphylaxis showed that 31 patients in their study group of 246 had second reactions before they got referred. So 23 to the same drug and 8 to a drug from the same structural group. This demonstrates that we should be serious and vigilant in supplying our patients with information about their allergic reaction before they leave hospital and even prior to further investigation. And we could use a standard letter like our difficult airway letter. Patients should be encouraged to carry the letter with them, and a copy should be sent to the family physician. This information should be updated as allergy testing results become available. So here at RCH, we have no referral protocol, and as far as I can tell, nobody's really keeping track of the allergic events. So thank you, firstly, for everybody who responded to my email last week. From the information I received, I can conclude that we are very good at the management of anaphylaxis, but there is room for improvement in the follow-up and prevention of future allergic events. I will end this talk with a list of ideas and information about the recent development of a perioperative anaphylaxis clinic here in in Vancouver, which will be very helpful for us. And my plan is to make the process easy and reliable to ensure safe future anesthetics for affected patients. So of the 31 cases that we had there in Edmonton over 7 years, only 10 were seen for allergy consult. 6 had conclusive results, of which 3 were confirmed to have allergy to latex, 2 to Ansef, and 1 to bacitracin. They had 1 inconclusive result to rocuronium. And this just demonstrates once again that consulting the allergologist alone is not enough. We have to follow up on the results. The allergologist can only do the testing, that is his expertise. We are experts in anesthesia drugs and in planning subsequent safe anesthetics. Failing to do so could lead to adverse outcome and have medico-legal consequences. So here at RCH, 2 of the 5 suspected cases were referred to allergologists. We know the results of 1 of these consults only because the patient is the sister of one of our OR nurses, and she was found to be allergic to bupivacaine and to clindamycin on skin prick test. Secondly, we rely on the allergologist for information on allergy testing. there used to be an allergologist across the street from here called Dr. Albert Chan, but as far as I know, he is retired. Some people were referring patients to him. The absence of a specific allergy doctor for referral is problematic in itself, as we need one that knows and has a special interest in perioperative allergic reactions. So even in Edmonton, where they did have a designated consultant, they had issues with faxing of referrals and trying to reach patients for their allergy consults and availability of the consult on a central computerized system. So, and then the third level is the lab work, and it's labor intensive. What they did, they're sending blood to France and then freezing or keeping histamine on, freezing the blood for histamine levels and then sending it to the Mayo Clinic in the US, and tryptase levels were done in Winnipeg, and then some of the stuff was done in Edmonton. So basically, some of the blood tests are not very sensitive anyway, so I'm looking at something simple. I'll tell you more about that. The ideal would be if all results were sent, eventually sent to the peri-operative allergy clinic for interpretation and final report, and this should be available on the patient's medical record with the report from the allergologist and the final recommendations from anesthesia as to future anesthetics. So in conclusion, my hope is that today's discussion will stimulate people to feel more responsible for the follow-up and safety of patients who have had allergic reactions under anesthesia. And secondly, I'm planning to construct a simple process for allergy testing, referral, and follow-up. And as discussed before, it is not an unrealistic aim to have a nationwide guidelines and a central reporting system in the future. Dr. Lujic is continuing to do work in this regard. Close collaboration between anesthesia and allergology is needed, and we are very lucky to have such a team right here in Vancouver. Most of you will know Dr. Jacqueline Trudeau, who finished anesthesia residency here at UBC last year. She has a special interest in anaphylaxis and a PhD. She got a PhD in immunology before she went to med school. She has been working to secure funding for a peri-operative allergy clinic every few months. She works with an allergist. His name is Dr. Donald Stark, and she has had several referrals from all over BC. And the consult, I saw two of the consults, and they're really detailed, and they're very good. And currently, she has had a few clinics already, but it's out of the office of the allergologist. She's still working towards a nurse and pharmacy supported clinic in the hospital. I am meeting with her once she's back from vacation. Both of us were on vacation, so we couldn't meet before this talk to discuss a formal referral process. So I will be bringing up the following ideas with her. Looking at referring every possible patient that we have here to her and her partner only, so that we have one place to send them to. This would simplify things and make it easier to get hold of the final consult and the test results. And secondly, I'm willing to be the RCH anaphylaxis contact person to coordinate and streamline follow-up, as well as keep track of any allergic events here. And then finally, patients need to be fully aware of their potential allergy. Secondary reactions before follow-up is not uncommon. And so an allergy letter to the patient and the family doctor could be a good way of transforming transferring information. And then we'll need to update it as we get information from the consult. And I'm willing to develop, to try and make a little easy thing for you to fill out, firstly to refer, and then also something to give to the patient. So thank you. And does anybody have any questions? Rob?
rocuronium, are the other ones safe or dangerous? The second question is, if people in Europe are being sensitized to rocuronium by exposure to something in toothpaste or shampoos, as you mentioned, why aren't they having anaphylactic reactions to the toothpaste and the shampoos and showing up in emergency all the time?
That last question I don't know, but with regards to cross-reactivity, it's 60 to 70% between the different muscle relaxants. So that's why they recommend if somebody has a severe allergic reaction to one, it's useful if you can test for the rest so that you can find a safe one, because they're usually not allergic to all of them.
So if someone tells you they're allergic to rocuronium, but you really don't have any, if you don't have any formal allergy testing results,
it's going to be difficult.
The natricurum, cisatricurium would also be triggers.
Well, I would ask more about the allergic reaction.
Sorry, I guess, is there any benefit as an add-on to Rob's question between switching from an aminosteroid to a benzoyl-isoquinolone?
Yes, I wonder where I missed the slide or so here about, yeah, you could switch because the one or two of my slides didn't show up, so I'm just gonna. There. Did I show you these ones?
So immunosteroids are actually.
So SUX is still the most common culprit for allergic reactions, and then the benzyl isoquinolones are more likely to cause allergic reactions than the aminosteroids. And then you also have to remember that histamine release that you get with mivacurium and atricurium, that's not a true allergic reaction. But basically, if you have to weigh risk and benefit if you're in the situation and you really have to use a muscle relaxant, then I would just switch to another class. I would also take a thorough history as to exactly what the allergic reaction was. And if it's an elective procedure and you have to use a muscle relaxant, I think the safest thing would be to defer the surgery and send the patient for an allergy consultation. That would be the safest thing to do. Whether that's the most practical is another question.
I have comments.
Yes, okay.
The only one interesting comment is the only contact I've had with an allergist over reaction was years ago in London when I received a letter or a question from an allergist saying, this is a historical question. He says, well, what is this SCH and this STP stuff that the patient had? Because, of course, when you send a copy of your anesthetic record with abbreviations that are unknown to the world, then that's of no value. And so fortunately, though, with automated charting, that shouldn't be a problem now. But that's a thing to keep in mind, that allergists don't know anything about any of our abbreviations. So if you communicate with somebody, you've got to use full terms. We still see a little bit of these unknown abbreviations, LEA. What the hell is an LEA? Labor epidural analgesia, apparently, but that means nothing to me on a chart in the recovery room. So the second comment I have is that I think you're correct in noting that we need, Edward Chan is the guy's name, and he's retired, as I understand, too. So we need to identify a single local allergist. There must be one. Don Stark actually is pretty old, and he'll be retiring soon, too, so I don't know what Jackie's going to do.
Jackie's very young, and she's resourceful, so she's very likely to find a young allergist.
There's another
allergist. We probably need a
local
person to refer to. And then the third comment would be that this is a absolutely perfect thing for this new physician payment funding model that's come up, which if you were at the medical staff meeting, and as part of that, basically that will pay physicians for their time in establishing patient care things. And so the question would be, should we set up our own as opposed to using the VGH thing? And then actually even a fourth question would be, we often receive patients from the wards who are said to be allergic, had an allergic reaction to such and such, and would be better to set up a hospital. I mean, I'm looking bigger, a hospitalized process if somebody is said to be allergic to NSF should they receive referral to a proper clinic for evaluation of that question, so that when they subsequently come back to the OR, it's resolved before they come to us. That's all I have to say.
Who was first, Guy or Ken? I don't know.
Guy, probably.
Mine's a very practical, almost basic question, comment. I get funny looks in the OR, but is anybody else like me? I never run antibiotics during induction. I will interrupt the antibiotic.
Yeah,
and,
some people.
and I get really funny looks from a surgeon. I say, once they're intubated, I'll restart it. But and to me, it's not that I think I'm going to make things worse, but I'd like to know if I get a rash or if I get a reaction of any kind. At least I'll have an idea of which agent it is, because as you say, most reactions happen within 5 minutes.
Yeah, I know some staff people
Right?
I work
Do you
with in
know which
Edmonton
agent
that
it is
does
if
the
you're
same.
giving
I'm sorry?
Do you know which agent it is if you're giving 4 other drugs?
No, but the most common ones are your antibiotic and your non-depolarizing muscular blockade. So at least if you separate the antibiotic from the rest of your induction, because people often say, oh, it's the ANSEF, it's the ANSEF. If you're doing everything at the same time, you've at least eliminated one.
I guess the difficulty is
If you just stopped it.
even if you stop it for
Yeah.
5 minutes and then give the antibiotics,
Already
it's still going to be
You don't
temporarily
really
very
know.
unclear to me.
Yeah, well, for me, my goal is, and I'll leave cardiac out of this because I do a very different routine for cardiac. Cardiac I actually induce with that, but it's because I started as soon as I get my IV in, and by the time they're induced, it's all in. But I either get in well before we start, or else it doesn't get started until we're prepping.
But then you might not have it in for 15 minutes before your incision.
I don't care.
This is a great talk and a really interesting topic. Just following up on some of the comments that Richard made, I mean, these are fairly rare events still, so
Correct.
a homegrown version of this to me doesn't make as much sense as getting involved in something that's either citywide or province-wide and ultimately nationwide. The liaison with Jackie Trudeau, I think, is excellent, and I think in terms of the physician funding, in terms of any of the work that goes on locally, that's a really good way to recruit people who are actually going to put in some effort to make it happen. But I think because it's a rare thing, centralization of this process, I think, makes the most sense. But in terms of developing a protocol, certainly we could create a model